We've got two terrific panelists here today. Gil Welch is a physician and a professor at Dartmouth School of Medicine, and he has also written numerous, I want to say hundreds, thousands, millions, many papers on this topic of cancer screening in journals like JAMA, places like that. Jessica Herzstein is an internist trained in preventive medicine, has also done a lot of work on occupational and environmental medicine. She's at University of Pennsylvania, and she's also on the U.S. Preventive Services Task Force. So Gil, I wanted to start with you. You've actually written a book about cancer screening, and the title is, Should I be Screened for Cancer? And the answer is sort of embedded in the title, isn't it?
Maybe not, and here's why.
Right. So, why not get screened for cancer? It's kind of just in case. There's no harm done, right?
Well, I think it's really important to understand the dynamics of cancer screening, and the first thing to recognize is to screen a population, one has to involve literally thousands of people to potentially help a few. And I've always asked the question, if you have to involve 1,000 people in something and 999 aren't being helped, what happens to them? And I think there are three categories of things that happen that are undesirable. The first is, in order to promote cancer screening, we have to induce or inject a little dis-ease into the population. We have to get people to be worried about the future, and have to get them worried about a potential disease. And I think it's something, as healthcare providers, we have to be careful about introducing too much dis-ease into the population, because part of health, of course, is about a state of mind, not simply a state of physical being. So there's that general anxiety used to promote cancer screening. That's the first one. And fear,
right?
Absolutely. The second problem is the false alarm problem, because we're trying to cast a really wide net. You can kind of think of it like dragging the ocean bottom for fishing for scallops or something. You get a lot of bycatch. You get a lot of false alarms. And these are abnormal tests that get patients worried, even more, understandably. And then they lead to a whole bunch more tests, sort of a haphazard process of more testing, some of which has real complications associated with it, particularly when we need to get tissue. And I should also add, it can cost a lot of money, and increasingly it's coming out of patients' pockets. And those are the false alarm problems. And then the third problem is the overdiagnosis problem, and that is the most unfamiliar problem to the general public. But whenever we look for early forms of cancer, we find a lot more than we ever expect. And that means we're beginning to find things that would never otherwise become evident to patients. That's a pretty foreign idea. Not all cancers ultimately matter to patients. And we're learning it more and more now. As we screen more, we realize, well, there is a reservoir of these extra cancers, and that's really begun to change the way we think about cancer. It's actually changing the view of cancer and recognizing it's a very heterogeneous group of disorders, and it's been described as the barnyard pen of cancers. And there are three animals in the barnyard. They're the birds, the rabbits, and the turtles. And the birds, and the goal of early detection is to try to fence these animals in. And you can imagine, you can't fence in a bird. It's already gone, and these represents the fastest growing cancers, the most aggressive cancers, the ones that have already spread by the time they're detectable. Then there are the rabbits. They're hopping around. If you build enough fences, you will catch some of those early, and that's where screening arguably will have its most important effect. But then there are the turtles, and the turtles aren't going anywhere anyway. They're just moving around and not going anywhere. They don't pose threat to people. And the problem with screening is really good at finding turtles. Doctors can't tell what's a turtle and or we have some hints, but we can't be sure which is which, so we treat everybody. And that means we're treating people who will never experience problems from their disease. And that's a long answer, but those are the three categories of harms. It's the general anxiety used to promote screening, it's the false alarm problem, and it's the problem of overdiagnosis.
Mm-hmm. So Jessica, you're on the U.S. Preventive Services Task Force, and so one of your jobs there is to assess screening tests and make recommendations. So my question to you is, what makes a good screening test? But I think before you answer that, maybe you could give us a little bit of background on the task force, who you are and what your mission is.
Sure. Good morning. So the United States Preventive Services Task Force is charged with setting evidence-based guidelines for preventive health services. The services include screening, preventive medications, and counseling services. So we do a wide range of things, and we produce a lot of recommendations that are easily visible on our website. And we have a lot of detail, and I really recommend you take a look at the website for any area of screening or preventive services that you're interested in. The way it works, we are a group of 16 health professionals with expertise in preventive medicine, primary care, evidence-based medicine, and representing different fields in primary care like internal medicine, OBGYN, family practice, and behavioral counseling. And we are carefully vetted to not have any conflict of interest, personal, professional, financial. And that's one of the important factors, I think, in the goals of our program, to set evidence-based guidelines that are truly set based on the data and not on any other professional or personal concerns. The way the process works is kind of interesting. We try to be very transparent, and we publish the work that we do as we do it online. So first we develop a draft research plan. Well, I should say first we develop a topic list, and the topics can be proposed by the public, by medical professionals, by people who we work with, and then we prioritize the topics, and then we set up a research plan. A group of us meets together with epidemiologists and statisticians, and we set up a research plan, and that goes online for comment. And then after that, we devise a analytic framework and a plan for exactly how we're going to do an evidence review. The evidence review provides very detailed information on the tests and the benefits and the harms, and the group then meets and discusses what are the benefits and harms of each step in the testing. So if you take a certain population and you do some tests, do you find an increased incidence? Do you find the cancer early or the disease? It's not just cancers. In a different subpopulation, maybe at higher risk or different ethnic group, if you do the test, do you find it? And what are the harms of doing the testing? And then you move along across the analytic framework, across the flow sheet, and you determine what are the benefits of finding this disease early, what are the harms of finding the disease early, and ultimately what we're looking for is health outcomes like reducing mortality and improving quality of life. It's not so much that we want to find more of a given disease. We actually want to improve people's lives. So that's a step that is very important to us to determine if the health outcomes are actually met or not. And then we assign a grade to the evidence that we have found. The way we do that is we carefully look at a grid of all of the benefits and the harms, and we weigh the magnitude of each of the benefits and harms for the different testing or counseling or whatever services, and then we look at the certainty that we have. And based on the magnitude of benefit and harm and the certainty, we determine the net benefit. And the net benefit is what we use to set the grade, as well as the certainty. The grades A and B are basically very high to moderate certainty of a significant to moderate effect on a health outcome. And then the C is probably some small effect, but it's more difficult to say who would actually would benefit from this and who wouldn't. So that then we recommend individual advice and counseling with your physician to decide whether that's going to be beneficial for you. And then a D recommendation is really, we see no benefit to this or actually more harms than benefits. And an I is there's insufficient evidence to determine the benefits and harms and what recommendation we can make. We try to stay away from I's, but that brings me to what one of the goals of our group is to generate a lot of, to generate research. And we recommend research that will fill the gaps of what we have found on, is missing in our analysis. And that research can be funded through NIH and Congress and all. And then we see studies coming along that will actually help us get off the I's, as we say, and determine with more information which groups are going to benefit and which aren't. And one important piece I want to mention is that we do not consider cost. And as important as cost is, we are not charged with doing that, and we in no way, we don't even know the costs of things that we're looking at. So that's not to say that cost shouldn't be considered in what's rolled out or what's offered in various healthcare plans, but we don't do that. So we're just simply saying what works and what doesn't work and what we don't know. That's the task force.
Great, great. Yeah, it's interesting to note that there isn't cost involved, because I know that your group has been, there's been a lot of accusations that fly when the recommendations come out and certain groups don't like them, that this is about rationing and things like that, but that's not the case.
It's just based on evidence.
Yeah. So Gil, how can it be that cancer screening can be not helpful in some cases when we have all this information and you see ads about, 5-year survival rates are really going up and isn't this great? When it's caught early, the survival rates are so good.
Right, yeah. This is the problem with early detection. There's so many counterintuitive parts to it. And whenever you look early for disease, you find more people have the disease. And of course, the typical patient with the disease does a lot better. And one way to think about this sort of extreme example that helps everyone understand why survival is such a bad metric in the context of early detection is to imagine finding cancer in all Americans, which we're getting close to being able to do. We could literally find cancer in all of you. If we looked hard enough, we included the thyroid, we included the prostate, places we know there harbor lots of small cancers. What would the survival rates for cancer be in the country if everyone was found to have cancer? Well, they'd be unbelievably high, right? They'd be unbelievably high. So survival statistics are, I think they're about the most misleading statistic in medicine in the context of early detection. Whenever you're trying to find more early disease, of course survival goes up. The real question, as Jessica said, is does the death rate from cancer go down? And that is actually a much more difficult question to answer. Anybody can find early forms of disease. It's just not very hard. And in fact, one of the things I think is really important for us as we go forward is to recognize that the goal of early detection is not to find more disease. It's not to find more early disease. It's to reduce the amount of, the rate at which people present with advanced cancer. Take someone who's going to be destined to come with advanced cancer, turn them into an early cancer, and it looks like that doesn't happen nearly as much as we'd like to see, and that's the problem with the birds. Mm-hmm. And to have fewer people die from cancer. And that takes heroic studies involving tens of thousands of people who are followed for 15 years. So it is a very, very challenging area to even know what the real effect is on mortality. But what is very obvious is the very quick effects of more people being diagnosed, more treatments, more false alarms, more procedures. Now, how you weigh these kind of things, these benefits and harms, and I don't know quite how you guys do it, because it's hard. It's about value judgments. Do I believe that if you screen a whole population aggressively, you might help one or two? Yeah, I think you do. But you also harm many, many more. And I know it's apples and oranges. There's no one right answer. These are value judgments. But they certainly aren't the most important things we do in medical care. And this is something that's really gotten conflated. You know, we've acted like screening is the most important part of medical care. Like, come on. The most important part of medical care is how well do we treat those who are acutely sick and injured. That's the most important part of medical care.
So Jessica, when the task force is looking at this, Gil was just saying it sort of comes down to value judgments. How do you weigh the benefits versus the harms? And especially when the magnitude of the two may be different, but how do you compare a saved life to a wrecked one, right?
Yeah. It's very hard, and I have to say that's the toughest part of what we do. And we are the first ones to recognize that a lot of this comes down to individual preferences and values and personal choices. And we say that, and we encourage physicians to have these discussions. And what our goal is really to encourage patients to understand more about this so they are empowered to make these decisions. It's not a right or a wrong. It's not that you should have this screening and you're wrong if you don't have it. In almost all these cases, it's really a personal decision. And the more that clinicians and patients can understand this, the better off they are. We try to evaluate the benefits and harms with the grid that I was mentioning, but in some cases it's very clear. In other cases it's really, so much comes down to personal decisions, and that's where we would have trouble giving it anything but a C or an I. It's tough.
Gil, when should the decision about this be made? I mean, do people just get a test and then decide later?
No. This is something I think we all need. We all need to understand the two sides of early detection. It does have the potential to help people, but it almost is guaranteed to harm others. And I think we're entering a world where, first, there are very strong financial interests at work here. I mean, this is the easiest way to expand the patient population, is to turn people into patients. And there's a lot of interest in testing. Testing is, and what kind of tests do you want? Do you want tests that are just for patients with rare diseases? No, you want tests. You want to produce tests that go population-wide. And so screening has a very attractive appeal from the financial side of business. But I think it's very important for the general public to understand the two sides, because we're about to get a barrage of biometric testing and genetic testing and epigenetic testing. I fear personally, is a recipe for making all of us sick. And it comes back to what the word health means to us. It's a discussion I think is very much needed.
Mm-hmm. So sort of in general terms, Jessica, what are some of the characteristics of a good early detection, screening test? Are there some sort of basic characteristics that such a test should have if you're going to make a recommendation?
Yeah, so there are inherent characteristics in the screening test itself. You want a screening test that will pick up disease among people who have disease and not pick up disease among people who don't have it. So we're talking about sensitivity and specificity. And if you don't have good specificity, you'll find a lot of false positives, the false alarms that we're talking about. So those are characteristics. Sometimes we have the data on that, sometimes we don't, but they're very important, because when you're talking about screening thousands, hundreds of thousands of people, that's where you see the impact of a little difference in sensitivity or specificity. In addition, it's really important to think about the prevalence of the disease in the population, and that's where, when we start looking at rarer and rarer diseases, the potential benefits for people are smaller and smaller, and the potential harms are greater and greater. So it may sound good to be screened for some things, but unless you're in an age group and a risk group based on your family history or other things, it can be more risky to go through the tests because of the false positives. And it's not just saying, oh, it's a test, it's positive, but there's a cascade of testing that follows that for most things. So We don't do this so much anymore, but a chest x-ray, for example, which we still do sometimes, could find a little abnormality, and you go to a CT scan, you go to a biopsy or even an open lung biopsy or procedure in order to make a diagnosis that may just be, oh, it's a old, calcified infection, not harmful. So there are a lot of things that we don't necessarily want to know, and if the disease is in higher prevalence and the sensitivity and specificity are high, then we have a better chance of diagnosing diseases. We also want to find diseases that we can treat, and people sometimes forget that.
Which is a really key thing.
Yeah, it is kind of important.
We get all hung up
we get on the screening test
diagnosis,
is
and the real
great,
issue is can we change things. Yeah.
So, treatments change all the time, and we have to reevaluate what's beneficial for which people, and we're always trying to collect more data on more subpopulations, but it is important to think about, if I go through this test and were to have this condition or diagnosis, would I want this surgery? These are the potential outcomes, this is the potential benefits. If it's not very promising, maybe you don't even want to go there, or if there is no treatment for the disease.
And this comes back, if I can, to your question, which I never directly answered, sorry. But the time to make these decisions is upstream. Before you get involved in the testing process is whether, if the test is positive, would you proceed down the next load? Because otherwise, if you just start screening and enter the process, you can be found to be positive, and then you decide you don't want to do anything. Now you're all nervous about that.
So that's I think, so important. I think it's easy for clinicians just to check boxes and order tests, or just to say, you want to do this, right? And then send you off for whatever test. But prostate cancer screening is a good example of this. A PSA test, a blood test, is a very simple thing to do, and has been in the past pretty routine for men of certain ages. And now we understand more about this disease and this test, and it's not a good test. And since prostate cancer is so common in older men, it's
turtles.
Yeah. So we're going to diagnose a whole lot of it, and the more that you diagnose, then the more people are going to get treated. But it turns out that a lot of these prostate cancers are, as Gil says, very indolent, and you're going to die with them, not of them. And the treatments can be very, very harmful. For every 1,000 men screened with a PSA test, 30 to 40 men will have urinary incontinence or erectile dysfunction as a result. Some men will have heart attacks, and 1 in 3,000 will die in their surgery. So these were previously healthy people. They didn't have a problem that needed treatment that you've screened and now caused significant morbidity.
So is it possible that screening tests can actually lead to early death? Is that a possibility?
Yes. I know it's not
either from the testing or from the treatment.
Right,
from the
not directly
it's not the test itself, but it starts a chain of event. It can take healthy people and turn them into patients. And in our effort, it's never purposeful, but everything we do has some harms to it. Mm-hmm. And it can take someone who is well into someone who is sick, or worse, someone who's dead. That doesn't happen very often, but it does happen. Mm-hmm. And one of the things I think, as we think about, we're all trying to, maybe we aren't all, I'm not trying to live as long as I possibly can. I don't know what you folks want to do, but that isn't my goal in life. But even if that is your goal, you have to start balancing out the potential for harm that can lead to death. And you also have to recognize the timing of the events. Is screening's about the future. It's always about what might happen in the future. And it may distract your doctor from what's happening now, but the harms of screening happen now. They happen in the relatively near term. The harms from the operation, harms from the procedures, etc., for a potential benefit in the future. And I think that timing is relevant.
Mm-hmm. I wonder about the psychological harms as well. People say, oh, false alarm is nothing, and in some cases that may be true, but is there potential? I mean, do people think of themselves differently once they've had one of these false alarms? Does it create a sort of low-level anxiety that may linger?
We really need more research on that area, but evidence shows that with some tests and some cancers, yes, definitely, in some populations. And we are very concerned also that if they have a bad experience with a test and go through a lot, that they're not going to want to interact with the medical system when they do need to.
I think it's highly dependent on how the false alarm is resolved. If we resolve the false alarm saying the test was wrong, you are fine, that's one group, and that's it's done. But that's not how a lot of false alarms are resolved. They're resolved as saying, well, you don't have cancer, but you have something, dysplasia.
Yeah.
You have some abnormality that possibly puts you at higher risk for cancer. They leaves you somewhere in the middle zone, but we're not going to do anything about it. Right? You got some increased risk, something's a little abnormal, but we're not going to do anything about it. And I think that's where there is a real psychological problem.
The reason I ask, I once interviewed a woman who had had a mammogram finding where they said, oh, we need you to come back. And they didn't find anything the second time and said, well, you're probably okay.
You're probably okay.
And so then after that, she was going in. She said, it really changed things for me. And she was going in for a mammogram every 6 months after that, and was convinced that she was different now.
Yeah. It's a fundamental change.
Yeah. So maybe we should talk about the new draft guidelines on breast cancer screening that just were released to a smaller firestorm than last time, maybe?
It's true. So breast cancer is a common disease. It's a serious disease, and it's an important disease, and number one cancer for women in this country. And we recently reviewed all the data and there's a lot of data. There are a lot of randomized clinical trials and observational studies where we can learn more about the benefits and the harms. And it's a bit complicated, so I'll just try to summarize it. But again, more data, including fact sheets for the general public and for clinicians, and some of the numbers are all available online. We recommend mammogram screening for breast cancer for women in their 50s, from age 50 to 74, every 2 years. And that was a recommendation where we see the potential for benefit reduction in mortality optimized as compared to the harms, which, significant overdiagnosis with breast cancer. So there are a number of women who receive a diagnosis and are treated unnecessarily with all the chemotherapy, hormone therapy, and surgery. So we're trying to balance these, and the balance overall is very delicate in breast cancer. It's a good example of one that's very difficult and requires a lot of knowledge, so I think people should be informed, but also probably discussion with a healthcare expert to think through your risk factors. Where it's been particularly of interest is the women under age 50. For women in their 40s, there is potential benefit, but it's very small compared to the harms. So we recommend that be an individual consideration depending on a woman's values and preferences and risk factors, the most important risk factor being a family history and a first-degree relative, like a sister or a mother. And the concern there is that you could easily have far more women diagnosed and treated who did not need, and we're talking about younger women who will be treated for a longer time, potentially die from the treatment, or at least have some morbidity from the treatment. So that's a great concern of ours, and we spend a fair amount of time talking about the risks and how to think that through for women under 50. the chance of finding a cancer is much smaller in that age group, and the chance of benefiting a woman in that age group is much smaller. Again, it relates partly to the prevalence of the disease is much lower, so your chances of false positives. And indeed, for every cancer diagnosed in that age group, you see hundreds of false positives and biopsies, et cetera. So that's a careful decision that needs to be made. For women over 75 and over, we really don't have a lot of information. We don't know, and of course it depends on their state of health. And if they have other diseases and they're not going to live, but 5-7 years, it's probably not a good idea. But we don't have the data to say for women in general in moderately good health. So we rated that an I. And then there's a lot of new data on and interest in the additional screening procedures that can be done, like MRI and tomosynthesis and ultrasound, and how those might help. And we looked at those very carefully, several different ways, and we don't have enough information there either. We do bring out some of the pros and cons, and we are able to diagnose more cases of cancer with some of these modalities, but we don't have any information that we're actually saving lives by diagnosing those cancers. And were those cancers that were destined to really harm people or not? And finally, we looked at women with dense breasts, which you've probably heard in the news some. There's quite a bit of interest in that because women with dense breasts have a higher risk for breast cancer, not enormously higher, but a slightly higher risk of breast cancer. And unfortunately, a mammogram is less able to detect breast cancer in women with dense breasts. So it's a difficult situation. And we looked very carefully at information. We did a modeling study, too, on dense breasts. And even though we have this categorization, we're not good. We don't have enough information to say what to do with it. Some of the problems are that women who are younger tend to have denser breasts, and it's very, very common. 40-50% of women change categories from less dense to more dense when they have a subsequent mammogram. And you don't know if you have dense breasts until you have a mammogram. So right now it's a very confusing picture. And we don't know if looking at breast density adds anything to the picture and helping women make this decision.
I just want to jump in about that array of tests you're talking about, because we've been talking mammography, and then you mentioned ultrasound screening, you mentioned MRI, you mentioned molecular breast or imaging, or maybe you didn't mention it, but someone else is beginning to mention it's coming out. Yeah. And I want to be clear, the concerns are not specifically about mammography, as they are about the general approach of always looking for more cancer. We cannot make our judgments about how good a test is by how much cancer it finds. This MRI does find more cancers than mammography. Ultrasound finds more cancers. Molecular breast imaging finds more cancers. 3D finds more cancers. That's not the goal. In fact, that's a sign from my perspective that I begin to worry. We're already finding too many cancers. What you want to do is you want to find the cancers that matter. And so it's very important to have, I think, a more sophisticated idea about what you want out of a test. The test that finds the most cancers is not the best test. Witness PSA or witness ultrasound screening for thyroid cancer, which in Korea led to a 15-fold increase in their rate of thyroid cancer. No change in their death rate from thyroid. And this is not an epidemic in the classic sense of disease. It's an epidemic of diagnosis, because we all harbor, or not all of us, but pretty close to all of us, harbor small thyroid cancers. Well, people are losing thyroids. They're going on lifelong thyroid replacement. They're at risk to be, have vocal cord paralysis and small strokes during the procedure. These are things we really have to go slow on and recognize the two sides of the deal.
Mm-hmm. And now there's some evidence that there may be even another kind of animal, the dodo, right?
Yeah, dodo, yeah. Boy, you really read the book, didn't you? Yeah. This refers to cancers that go away. And that's a very, counterculture kind of thinking, but now we're realizing that the human body can react to small nests of cancer cell, and they may disappear. And in some organs, and it looks like the breast is one of them, where cancers can be found at one point in time, but aren't found in the future. It's a very difficult area to study, but certainly the cancer community is beginning to have a much more appreciation of the heterogeneity of what pathologists call cancer. And we don't have a great way to know which is going to matter.
And we also have a problem with deciding where the boundary is between cancer and not cancer, or disease and not disease. And that happens in so many cases. Like, where does thyroid disease start, and where does normal thyroid end? And these are just pretty much arbitrary decisions that somebody has set over the years, and they've actually there's a creep here, and they've grown so that it's much easier to be diagnosed with thyroid disease now than it was in past decades. And same with breast cancer with this DCIS. There's strong arguments from researchers and experts in this area that DCIS is not breast cancer, but there's still this creep to define things in a broader sense, and diabetes and lots of areas.
Yeah. You all harbor abnormalities. I can guarantee you that.
Yeah, and DCIS is ductal carcinoma in situ, and there's actually a movement now. The NIH had a conference to talk about the possibility of removing the name carcinoma from it, as they did. A similar thing happened with cervical cancer.
Yes.
They actually did that.
The labels matter, and I had the opportunity when I worked at the WHO's cancer shop, the International Agency for Research on Cancer, to meet one of the older pathologists that sat on that original panel back in the 60s that came up with the label. And he said he so regretted including the term carcinoma in there, because it did drive doctors as to how they treat things. And it does refer to the spectrum that Jessica's talking about. It isn't like these are black and white issues. There's a lot of gray between normal and invasive cancer.
And the person who developed the PSA test regrets that too.
Yes, there's a lot of regret out there.
Yeah. I wonder if we need to work on maybe changing the story. When you look at a lot of the messaging that's out there on this, it's screen, early detection is your best protection. That's kind of your classic message that a lot of the groups put out.
We definitely need to change the story, but it's a hard story to change because everyone likes to attribute prevention is better than cure, and then that seems to extend. Instead of prevention, of course, is a very broad concept that includes things like health promotion, which we can all sign on to, and eating better, moving more, that kind of thing. That's one set. But then there's the early detection efforts, which is really an effort to see whether we can find something wrong. And that just feels so good, like of course that's got to be good, but and then people throw out the saved lives language, which is actually very open to question when you start looking at all-cause mortality, which is what people think about when they hear saves lives. They want to know whether in fact we're going to live longer, so I think the messaging is of course part of the problem, but I think, to your credit and other people in the media, they begin to understand the two sides of early detection, and that helps.
It's sort of a self-fulfilling process too, because people who have been diagnosed with breast cancer and have gotten treatment and are doing fine 5 or 10 years later saying, my life was saved, and thank goodness I went for the such and such test when I did. But actually we know that mammograms pick up a minority of the breast cancers that will eventually be diagnosed, maybe about 12% out of the total who will develop breast cancer. So it's very possible to have a false negative mammogram, or as Gil was alluding to, you just didn't catch it at the right time. So that's disappointing. And also, mammograms and similar tests will diagnose a lot of cancers, but most of those women would have survived their cancer whether they were early diagnosed or not. So it's another consideration. Our treatments are so much better for breast cancer than they were in the past, and we have roughly a 30% decrease in mortality over the past 20 years. So by adding the early screening and early detection, we're giving women a longer chance to know they have cancer and to be under some unpleasant treatments maybe, but not necessarily are they living any longer than if they had developed, symptoms of the disease and gone to their doctor.
Right, it's the treatment, not the screening, that's saving the life, right?
That's
and so really, if there's a treatment, you don't need screening. Is that right, Gil?
The better we get at treating disease, the less important early detection becomes. We don't screen for pneumonia. Why? Because we can treat pneumonia. So screening is only considered when the treatment for clinically presenting disease is not very good. And in the case of breast cancer, that's the good news. Our treatment's a lot better.
And all of these women that were unnecessarily treated, they don't have the voice on the ads, so they don't have
because
the
they
story out there.
choose, and understandably, they choose to see themselves as having benefited from the test. And of course, I totally understand that, and I'm the last person that wants to suggest something otherwise, but the rest of the country needs to know that the survivors may represent the harms of the test.
And so, Jessica, I want to talk a little bit about your conclusion about women in their 40s and that it should be an individual decision, which I just wrote a story for Mother Jones about mammography. It's not out yet, but doing the research for that story, I went back and looked at some of the history, and it was almost word for word back in, what was it, 92, that the recommendations came out. The evidence is a little bit unclear. Really we want to make an informed decision, and
2009.
Yeah. No, but before that, in the early 90s. Yeah. Same thing happened. So this has been pushing for. Why do you think people are so adamant about saying we want you to say we have to have this?
Well, I think there's a lot of reasons. We've already alluded to the fact that women who are diagnosed and treated and done well are perpetuating this idea. There's also advocacy groups that stand behind this, and we see quite a bit of advertising and mailings about doing the testing. I think that, and we also have congressional people who promote this. Cancer in their 40s, breast cancer is quite rare, and so it's uncommon, let's say. So you're going to find a lot more false positives and potentially treat overdiagnosed cases more than so the harms are as great as the possibility of finding a cancer, and possibly greater. And that's where the individual persons, if they're really they place an enormous value on not dying from breast cancer, and they understand that that they are improving their chance of not dying from breast cancer by getting screened in their 40s by about 4 in 100,000, and they want to do that, though they understand what the harms are. I think that's fine. There's no right or wrong here, and we certainly allow women to make that decision.
Yeah, I think it's interesting to note, I've been reporting on this since I was in my 20s. The first time I was assigned the first time to write this story, and I started looking at the papers and was shocked, really shocked to see the disconnect between the messaging that was out there and the studies. It was really upsetting to me, actually, and I had friends with breast cancer, and this is an issue dear to my heart. I have family members and whatnot, but now I've reached my 40s, and so I had to make this decision. And it's my decision. I don't tell any of my friends or anyone else what to do. I agree with you that it should be a personal decision, but I've decided to opt out. And I made that decision because to me it's much more important to avoid becoming a cancer patient. I've seen what that's like, and that's something I would like to avoid at all costs. I realize that there's a very, very small chance, much smaller than the chance of becoming a cancer patient from the test, that I, by not having the mammogram will, miss a chance to avert a cancer death, but that's a decision that's okay with me because the payoff seems better. I have a friend who's also a journalist who has looked at the evidence. I'm confident she understands it, all of that, and she's made the other choice. She said, I have kids and I feel like I have to get tested, and that's her right. To me, if I don't have kids, but if I did, I would make the same decision because I think, I don't want to put my kids through me having cancer. That's more important, and dying, but it really is an individual decision, and there's the science, and then there's the values judgment, and science can't make that values judgment, right?
That's right.
And hopefully we'll have more and better research and better tests than PSAs and mammograms.
Or we'll use the same tests more smartly. You know, part of the problem isn't just the test; it's how we use what we react to and what our subsequent downstream algorithms are. And right now, we're in the find it, and not thinking about the cost of that. And I'm not talking about dollar cost, although there's a lot of dollar cost there. I'm talking about the human cost of the false alarm. If you really are looking hard, you're going to have a lot of false alarms and you're going to have a lot of overdiagnosis.
The
And
more that we
Jessica-
can narrow it down is helpful too.
I think we have questions, by the way.
Yes, we have about 15
We
minutes.
got, yeah, we have questions, okay.
Let's go ahead and start with the questions, right here. We need to get the microphone to you before you start.
Thank you very much, and I appreciate the overall perspective that you share, but I get concerned when I hear about aggregate information, because while there are greater harms to a broader group than the few that we might miss if we don't do it. And so I ask about the fact that we do have some better tests and screening abilities now to distinguish between the turtles and the rabbits and the birds. And even in prostate cancer is a perfect example.
Yes.
And so by missing those rabbits, we could lose people. And so why can't we do a better job by using that analysis and then also put more force on the physicians to use that information and not overtreat and overdiagnose, because we know that's coming from maybe not the best places. And now we're hearing what you're saying, it's putting pressure on us to take risks that maybe we shouldn't be taking.
I definitely agree we could improve the process. We could with existing tests, we could improve the process, ironically, by having a higher threshold to act, to not react to really small abnormalities, not to react to small changes in PSA, to look at stuff like grade. And you're right, we do have some capability to sort a little bit. And we hopefully we'll move that direction. But one of the important motivators for moving that direction is for the public to understand why we would do such a thing. Why wouldn't you look as hard as you possibly could? And that's why I think the discussion is so important.
I think one thing to support what you're saying is watchful waiting, which is now really being promoted for prostate cancers. When you have what looks like an early prostate cancer and you don't know at what rate it's growing, or there's no indication that it's growing quickly, to watch and look at it again in 6 or 12 months. And that could be done with things that are found on lung CT scans too.
Question in the back.
So I'm really curious. First of all, thank you for the very enlightening conversation this morning. But you had mentioned a lady from the U.S. Public Health Task Force. There were these scores you gave tests. And what is the highest score a test can get when looked at as a screening test?
Well, it's a whole mix of different things that go into evaluating a test, including the population that you're testing
When you're
in.
done, you said there was a category you didn't like, there was a category that...
Oh, about the grades.
Yeah, the grade. So
Okay.
what is the highest grade a test could get?
An A.
And how many A tests are you aware of that your committee is presently designated?
Oh, we have quite a few. I don't know the numbers, but
Can you name a few of the tests that then the committee has endorsed as being useful screening tests?
yeah, we have endorsed colonoscopy, or screening for colon cancer. It can be done a number of different ways. And I believe screening for lung cancer is a B. We have, let's see, what else is highly recommended? Yeah, cervical cancer, I think it's either an A or a B, but it's very highly rated.
But there are not that many A's.
So the changes have occurred in what we actually recommend for that testing. You know, when we recommend that testing be done, and it's an A or a B, we don't really differentiate a lot between how strong the evidence is, whether it was an A or it was a B. But I would say that we probably have at least 10 or 15 A's out there that have been done in the past.
And I know you've emphasized a lot about cancer, but would you care to say what the state of affairs of AIDS in the world would be without the screening test HIV?
HIV screening we actually promote in everyone, irregardless of risk factors, at least one-time screening. And
So that's a universal screening test that you would endorse in spite of the fact that the screening test itself has lots of false positives, and that's avoided by following up with confirming tests.
Yeah, confirming test is one thing. It's not followed up by an invasive procedure or anything. And certainly there's a lot of advantages we now understand to diagnosing HIV early. The treatment is so effective in preventing transmission to partners, et cetera. So
I'll ask one more question and then turn this over.
I think we should let someone else go because we
Okay, I'll
have
give the
room for only
microphone
one
to
more.
anybody you'd like.
So right up here.
I just didn't realize it was going to be quite so much about cancer screening. Can someone talk about, for instance, heart disease screening or allergy screening? We've been hearing a lot about some interesting technologies doing genomic testing relative to different interactions with specific drugs. I almost lost my husband to a drug allergy in the ICU. I just would like to know about the other types of screening, specifically maybe heart disease and dementia screening, and what your ideas are on
We only
that.
have 0 minutes.
0 minutes.
Yeah,
How do I handle 0 minutes?
30 seconds.
You got it.
EKG?
Well, let's just talk. I mean, one of the things is there a treatment? So for like Alzheimer's disease, I mean, that's a fundamental question. What are you going to do with a positive result? I mean, that's the fundamental question we should all ask. What are the downstream plan? I mean, it's easy to screen a population for things, and it's very hard to know what the right thing to do is. And so I think it's very important as we think about early detection is what are we trying to do, and what could we do, and think about what else might happen in a haphazard process that might not be in patients'
And would you
interest.
already be recommending some of those things?
Absolutely.
Because if somebody has a high cholesterol, is obese, is sedentary, you'd already be making recommendations and have them in behavioral change programs that hopefully would help them. So if you diagnose early heart disease, would that change anything you're already doing?
Same with diabetes, by the way. You know, there is a genetic test that can help add a little information about the risk of diabetes, but doesn't add anything relative to knowing someone's body weight and exercise habits. Why aren't we just talking to the whole is there anybody we wouldn't recommend eating well and moving more?
Yeah, so I guess we don't have till the top of the hour. Oh, okay. I'm sorry. I thought we had until the hour. So sorry that the Q&A is a little shorter than it should have been. All right. Thank you so much,
So we're
everyone.
supposed to dismiss people.